Hi, I'm Jim Lewis. I'm a gastroenterologist at the University of Pennsylvania, and I'm the principal investigator of the DINE-CD study, which I'm going to tell you about this evening. Before I start, I want to acknowledge my collaborator from the Crohn's and Colitis Foundation, Angela Dobes, who served as the administrative principal investigator for this study, and my friend and colleague from the University of North Carolina, Dr. Robert Sandler, who was the director of our Data Management Center. I also want to acknowledge our funding support from the Crohn's and Colitis Foundation, as well as the Patient-Centered Outcomes Research Institute, also known as PCORI, and funding from the National Institutes of Health and from a Sherman Award. This was a very unique research opportunity because the DINE-CD study, in many ways, was proposed by patients. We leveraged the IBD Partners online community to see what topics patients found most interesting to them. In this platform, patients like yourself are able to pose questions that they feel would be important to be addressed, and other patients can go in there and endorse those. And some of the questions that really rose to the top had to do with the role of diet in the management of inflammatory bowel disease. Before I tell you about the DINE-CD trial, I want to take a minute and just cover a little bit of vocabulary and the way we interpret these trials. So a clinical trial is any study where there's an intervention that's not part of usual care. So if you do something to a patient because they're in the research study, that's a clinical trial. A controlled clinical trial means that you're studying two interventions that or more that are able to be compared to each other. Sometimes one of those interventions is placebo, but they could both be active interventions. And a randomized controlled clinical trial means that the allocation of which intervention an individual patient will receive is determined by chance. This is very important because it eliminates the potential that sicker participants will get one intervention while those who are less sick will get another intervention, or that there's some other characteristic that will influence what intervention patients get, so that at the end of the trial, you're not sure whether the differences you're seeing are due to differences between the interventions or differences in the characteristics of the patients. So by using randomization to determine which intervention a participant will get, we eliminate that effect. And in addition, the larger the trial is, the more randomization makes the two groups or more groups that are studied in the trial look more similar to each other, so that at the end of the trial, any differences in outcomes can be attributed to the effect of the intervention. When we do these trials, we're always going to do some sort of statistical test to determine how likely it is that we would see findings like we saw in the trial based on chance. And sometimes you'll see that there are comparisons done between groups and other times within groups. You should mostly focus on the between group comparisons. These are the ones where we're thinking about, was it a causal effect? Did one intervention work better than the other and cause the outcomes that we've seen? Within group tests are interesting, but the findings are not necessarily due to the intervention. It could just be that you're seeing the natural history of the disease, or sometimes just being in a clinical trial, people change their behavior and you'll see differences in outcomes from the time that they enrolled in the trial to the end of the trial. Most statistical tests will be describe the results of these tests using what's referred to as a p-value. This tells us, again, how likely it is that we would see differences as big as we observed in our experiment by chance. A p-value of less than 0.05 is the traditional definition of statistical significance, meaning that the findings were unlikely, but not impossible, to be due to chance. When the p-value is 0.05 or greater, we say that the outcome was not significantly different between the two groups. However, it's really important to know that that does not mean that the interventions are equally effective. So the DINE-CD trial compared two diets, and one of these is the specific carbohydrate diet. This diet was first described by Dr. Sidney Haas and Merrill P. Haas, and they used this diet to treat patients with celiac disease, but that was before we understood what the causes of celiac diseases were. Subsequently, this diet was made famous by Elaine Gottschall in her book, Breaking the Vicious Cycle. Dr. Gottschall's theory was that the specific carbohydrate diet was predicated on the understanding that ulcerative colitis, Crohn's disease, and other conditions are the consequence of an overgrowth and imbalance of intestinal bacteria. And that by altering nutritional intake, we could bring back the balance in the intestinal bacteria and heal the digestive tracts. And shown in this schematic below, her theory was that there's injury to the lining of the intestines. It leads us to poorly absorb carbohydrates. The bacteria there consume those carbohydrates, grow and ferment them into toxins that cause more mucosal injury, and that the cycle would recur. The other diet that we studied in the DINE-CD trial is called the Mediterranean diet. You've probably heard about it because it's been associated with many different health benefits. Within the general population, it's been associated with a lower all-cause mortality, as well as a reduction in the risk of heart disease and cancer. And for patients with Crohn's disease, it's been associated with being less likely to be diagnosed with Crohn's disease. And for those patients who already have Crohn's disease, use of this diet has been associated with reduced symptoms and improved quality of life. So just to compare these two diets before I tell you about the results of the study, the specific carbohydrate diet is characterized by a high intake of unprocessed meats, poultry, fish, and eggs, most vegetables, most fruits and nuts, and some legumes, but avoidance of all grains and dairy other than some selected hard cheeses and homemade yogurt that's been fermented for 24 hours. And the only sweetener in general that is used is honey. The Mediterranean diet, on the other hand, is characterized by a high intake of olive oil, fruits, vegetables, nuts, and cereals, a moderate intake of fish and poultry and wine, and limited intake of red and processed meats and sweets. So they have some things that are in common and others that make them different. The design of the study was a 12-week, what's referred to as a parallel group randomized clinical trial with 194 participants, where we compared these two diets. And the main inclusion criteria were that people with Crohn's disease had mild to moderate symptoms and were on stable dose of their medications. And then we excluded people, for example, who were pregnant, who had an ostomy, had known strictures, meaning narrowings in their intestines, or who had been using the specific carbohydrate diet within 4 weeks prior to screening. This schematic shows you the overall design of the trial. So the trial ran for 12 weeks, but the primary outcome was assessed at 6 weeks, and that main outcome measure was symptomatic remission. And one of the key features of this trial was that for the first 6 weeks, we provided participants with all of their meals, ready to eat, breakfast, lunch, dinner, and 2 snacks a day. And you can see an example of a specific carbohydrate diet dinner on the left, and a refrigerator full of prepared meals ready to be heated and eaten. During the second 6 weeks of the trial, participants actually had the opportunity to purchase food from our vendor, but most opted to actually obtain their own food, mostly likely cooking their own food. We screened 460 potential participants to identify 197 who could be randomized, but 3 of these people actually dropped out before they had the opportunity to start their study diet. And then there were a few others who we had to exclude from the analysis due to a technical error, leaving us 191 participants in the final efficacy analysis. So here are the main results at 6 weeks. You can see that symptomatic remission was achieved by 43.5% of the participants on the Mediterranean diet and 46.5% of those on the specific carbohydrate diet. Clinical remission measured with a slightly different measure was almost identical to that of symptomatic remission. Reduction in bowel inflammation as measured with calprotectin was seen in approximately 31% and 35% of the two groups. And CRP, a marker of systemic inflammation, normalized in a very small proportion of the patients, approximately 4% and 5% of the two diets respectively. And you can see by looking at the p-values that none of these differences were statistically significant. If we look at the within group comparisons, however, you can see that in both diets, with both diets, patients tended to feel better over the course of the first 6 weeks of the trial. And that didn't matter whether we were measuring symptomatic remission, as I mentioned with the short CDAI, or if we looked at quality of life with the short IBDQ, or at some other features such as fatigue, pain, sleep, and social isolation. And this was true for both of the diets. However, the amount of improvement on the two diets was not significantly different when you compare between the two diets. And then here are the results at week 12. Remember, in the second 6 weeks, participants were on their own to obtain their food. And you can see that the results were relatively similar. And again, none of these reached traditional levels of statistical significance. So in conclusion, both of these diets were well tolerated despite increased consumption of fruits and vegetables. And we note that this is not something that we necessarily routinely have recommended to patients who had active symptoms in the past, but maybe what we've learned from this is it is okay to recommend patients to go ahead and consume more fruits and vegetables. Symptomatic remission was relatively common with both of the diets, but specific carbohydrate diet was not more effective than Mediterranean diet for any of the outcomes. And neither diet was associated with normalization of systemic inflammation as measured by CRP. From that, I think you could say that either of these diets could be tried to improve symptoms. I will note that the other health benefits that have been observed with the Mediterranean diet may make that the preferred diet for most patients, albeit I should also note that the specific carbohydrate diet has never been tested, to my knowledge, for those other health benefits. So I can't say definitively that it wouldn't have those same other health benefits. I would, however, also note that the Mediterranean diet is a bit less restrictive and so quite a bit easier to follow. And if a patient does work with their physician and decide that they're going to use diet as part of their treatment algorithm, I'd also just like to emphasize that it's important to assure that the inflammation is resolved, even if the symptoms have improved. I'd like to just acknowledge the many, many different sites who participated in this trial and the local principal investigators who made this happen. And most importantly, I would like to thank the patients who participated in the DINE-CD trial. Without patients being willing to participate in clinical trials, we would never move forward in understanding how best to take care of patients with Crohn's disease. And I think we owe all of these patients really some gratitude. And I hope that if you ever have the opportunity to participate in a clinical trial, you will definitely consider it. Well, thank you again for joining this symposium, allowing me to tell you about the DINE-CD trial, and I hope you enjoy the rest of the evening.